My name is Dr. Clement Nmuka. Today I'm going to be talking about ruptures of the heart because as an effect of an MI or a myocardial infarction or a heart attack. This is a dramatic event in that if you start from outside, there will be inflammation of the pericardium. The pericardium being the outside lining, the lining of the heart. And how do you see this? It generates a pain which is the same as that of stable angina, unstable angina. It's a pain. And it becomes worse, this pain, when the patient coughs, when the patient inhales, breathes in, it becomes worse. And when the patient is changing the posture, changing the body position, changing the body's position, it becomes worse. Then you know that's pericarditis. Oh, it normally responds to anti-inflammatories. Just give anti-inflammatories like Voltaren, anti-Indocid. If you give anti-inflammatories, it normally subsides. But now, if we have to go to ruptures of the myocardium, the first one is to think of the left inlet valve. That's your mitral valve, left inlet valve. The one that is between the left filling chamber and the left pumping chamber. That's your mitral valve. If this one is ruptured, you see a torrential motion of blood back to the lung. Oh, that's an unfortunate set of circumstances. Back to remember the blood is coming from the lung, it has been oxygenated, it's supposed to be pumped out of the body, out of the heart to all the parts of the body. But that's not happening because of a ruptured mitral valve or a ruptured inlet valve, the one on the left. So everything, the blood now, which was supposed to go for, the unilateral motion is disturbed. Now there's reverse motion, blood torrentially back to the lung. That's the first. If you know the septum that separates this left ventricle from the right ventricle, or the left in pumping chamber and the right pumping chamber, if that one gets ruptured, so there'll be now motion of blood from the left pumping chamber to the right pumping chamber. That's normally a problem. It's a very serious problem. Even in good hands, the expert hands, this is a fatal condition. It needs nothing else but repair or replacement of replacement, or shall I say heart transplant, because then that's about the only thing that you can do with this. Sometimes you get a rupture of the myocardium, that is the myocardium of the ventricles, such that blood spills over and it gets into the pericardium, the lining. It gets into the, this one is also a lethal condition. You know, patients, it's a fatal condition. It gets in, you know, you can imagine blood, it's this bleeding heart, the blood getting into the pericardium. This is one of the worst things that can happen. So that is why it is crucially important to prevent a situation like this by treating, like I said, before an earthquake, we normally get a tremor. You treat the tremor. The tremor is your what is so crucially important, that pain, stable pain, angina, going to an unstable angina. So treatment of the unstable angina is the one that is so crucial to try and prevent. In fact, both of them. But if it gets to a stage of an unstable angina, for goodness sake, make sure that this is treated so that it doesn't get to a myocardial infarction. Myocardial infarction is exactly what I'm talking about, where there's rupturing of this. Sometimes when the rupture is severe, blood is unable to get to the brain. And if blood is unable to get to the brain, or it gets there but insufficient amount gets to the brain, what you notice is confusion of the patient. Blood pressure that goes right down. And the reduction of blood going to the kidneys. And once that happens, there'll be reduced renal output or urine output. So if you have got these three things, you've got confusion, and you've got reduced renal output or urine output, and you've got a low blood pressure, in other words, the hypotension. Those three, they constitute what is known as a cardiogenic shock. This shock is caused by, and something else happens. If you look at the capillaries, the skin capillaries, or the skin blood vessels, they constrict to try and get the blood to, the brain should never run short of blood. So the best thing, let me constrict, the skin must get nothing. Let me constrict the blood vessels of the skin. And what does this give? It gives a very cold, the patient becomes cold because there's no blood going to the skin. And also the skin becomes sweaty. So this is a problem. And this happens whenever you have cardiogenic shock. And these are some of the complications that if you get to a stage of a cardiogenic shock, man, if nothing is done about it, patient, it's a fatal condition. So if you see a confused patient and you look at the blood pressure is low, and you look at the urine output is reduced, that's a cardiogenic shock. Cardiogenic shock, that's an emergency. That patient, normally it's a fatal condition. But one has to do a lot of things. If with young patients, they are candidates for heart transplant. Otherwise, generally these are bad, and you're not supposed to get to a stage where you get so cardiogenic shock. You think about a confused patient. You think about a hypotensive patient, a patient who's got hypotension, in other words, low blood pressure. And you think about, you look at the urine output, you notice that it is reduced. This is a cardiogenic shock. And you must check, where's the blood loss? How is the heart losing blood? Is it because of a catastrophic event where blood, is it because of a catastrophic event where blood is from the left ventricle and it gets into the pericardium and the lining of the heart? If this happens, that's a fatal condition. We just don't like it, and we say we need to do something about this. Well, that's not my patient, for instance, as a primary healthcare doctor. Primary healthcare doctor doesn't deal with such patients. The patients like that are dealt with by the cardiologists, by the specialists like the physicians. And those are the people who look at that. So we, from our side as healthcare workers, primary healthcare workers, we look at clot busters. We look at making sure that we do away with the clots, because we can give medication for that. But we don't want to get to a stage where we have the actual heart attack, where we have rupturing of this, where we have pericarditis. Pericarditis, the patient moves, it's a big problem. When he moves, the patient, the pain intensifies. It's as if it's that unstable angina. It intensifies. You know, we don't want to get to that stage. When the patient breathes in, the patient screams with pain because, because then that tells you straight away that the patient has pericarditis. The patient changes position, the posture changes position, the patient cries because of pain. So this is what we are worried about as far as this is concerned. We are worried about the rhythm as well, the disturbance of the rhythm. Remember, the rhythm is set, actually, the rhythm of the heart. And it is regularized by the sinoatrial node, which you find on the right, the right atrium, right on top there. It's the one that sets the pace. So now, we don't want it disturbed. Let me tell you, during a myocardial infarction and during a heart attack, that regularization is disturbed. So we've got what is known as a rhythm disturbance. And I'm still going to talk about that. Rhythm disturbance caused by an MI, myocardial infarction, or heart attack. So this is what one has to look out for. Has to look out for which stage are we? Are we at the stable angina stage? Are we at the unstable angina stage? Are we at the myocardial infarction? We don't want to talk about it because this is the one that gives ruptures to the myocardium. It gives ruptures. If there's a rupture of the septum between the left ventricle and the right ventricle, blood is going to be pushed out from the left to the right side, and that's the worst that can happen. Remember, the right side is supposed to have deoxygenated, everything that is there, deoxygenated blood. And now we have oxygenated blood, which is supposed to go to all the parts of the body. It's now mixed with this. This is sad. Normally patients don't make it. Even if they are in good hands, they don't make it if that has happened. In other words, a defect, a septum defect between the left ventricle and the right ventricle. That septal defect, which causes migration of fluid from the left to the right. And that's not what's supposed to happen. It's supposed to go through the aorta and go to all the parts of the body, and not to go back to the heart. Not to go back to, because now it's going back to the heart. If it goes to the right side of the heart, then that's not right. It's because of a septal defect. But we know that if it is the mitral valve that is defective because of MI, myocardial infarction, or heart attack. If it is the mitral valve that is defective, it can be defective. Even, it can be defective because if it is ruptured, then you'll see this torrential flow of blood back to the lung. And that's unfortunate. That's not what you want. The lung is not going to be able to handle that torrent of blood that goes back to it. And this is what one has to. It's good to know this, because you will know what is it that you need to prevent. You will know that I don't want a situation where blood, which is supposed to go to all the parts of the body, now this blood goes back to the lung, and that happens. Well, we spoke about this when we were doing heart failure, but that was blood going back, and that blood gave rise to a high pressure in the lungs, a congestion of blood in the lungs, which gave rise to that pressure pushing the water out of the blood into the alveoli, or into the essex, and that's disturbing what? That's disturbing gaseous exchange. Because remember, the essex of the alveoli, they are there for gaseous exchange and nothing else. So now, if there's a torrent of blood going back to the lung, that's unfortunate. That's not what we want. You must remember that blood was supposed to go to all the parts of the body, including the heart itself. It's supposed to, remember, through the coronary arteries, it's supposed to come back to the heart. And that's not happening. Thank you very much. Thank you very much. I'm glad you've listened to me. The next time I'm talking to you, I'll be talking about the disturbance of the rhythm as the major thing. And what is it that we can do and it's all because of an MI, myocardial infarction. It's all because of a heart attack. Disturbance of rhythm, which is set by what? Which is set by the sinoatrial node, or the SA node. That's supposed to be the battery of the heart. The battery of the heart. There's no heart that would start anything. A car doesn't start if the battery is not there. You need a battery. So that's the battery of the heart. It disturbs that. Thank you very much. Thank you very much for listening to me.